All right, welcome to the deep dive. We've got a pretty hefty topic lined up today, all about potassium, but more specifically, hypokalemia. You guys have sent in a ton of resources, articles, case studies, all kinds of stuff.
Definitely a popular one.
Yeah, really comprehensive too.
Yeah.
But, the mission today is to kind of boil all that down. We're going to
Yeah.
distill it, especially for those of you out there who are post-grad docs, getting ready for those big exams like USMLE and ABIM. So think of this as your super focused study session.
I like that. Super focused because, let's face it, potassium imbalances and hypokalemia specifically, we're talking bread and butter stuff here.
Oh yeah, constantly cropping up.
Every rotation, pretty much. And we all know it can get serious fast.
Absolutely life-threatening if you miss it
You bet.
or if you don't manage it properly, especially in acute care. So mastering this is crucial, not just for acing those exams, but obviously for taking good care of patients.
Exactly. So where do we even begin with all this? I mean, we could talk about potassium for days.
Okay, so here's the plan, the roadmap for today's deep dive. First, we're going back to basics. I know, you've heard it all before, but trust me, it's good to refresh the fundamentals. What exactly is hypokalemia? Why does it even matter if potassium dips just a little bit?
Gotta have that solid foundation.
Then we're going to systematically walk through the clinical features. What should make you think, maybe this patient has hypokalemia? After that, the causes. We'll break it down. Renal versus non-renal, genetic factors, hormones, those pesky medications, and of course, investigations. How do you actually get to the bottom of what's causing it?
That's where it gets interesting.
Diagnosis, obviously. And finally, the management strategies. We'll hit on those special scenarios too, like DKA. And because everything's connected, we'll wrap up by looking at how hypokalemia plays with other electrolytes and acid-based disorders.
Right, I'm ready if you are.
Let's do it. Let's say you've got a patient right in front of you. What's going to tip you off that they might be dealing with hypokalemia? Clinically speaking, what are those signs you're looking for?
Okay, so first things first. Before we even jump into signs and symptoms, we need to know what we're dealing with in terms of severity.
Right, categorize it.
Exactly. So we classify hypokalemia into three main categories: mild, moderate, and severe. Mild is when potassium levels are between 3.0 and 3.5 millimole. Moderate dips a bit lower, between 2.5 and 3.0. And severe, well, that's anything below 2.5.
And that's not just for textbook definitions. Those numbers matter.
Oh, absolutely. They tell us how quickly we need to act, the urgency of the situation. But before we even get to that, we need to remember why we even care about potassium in the first place, what makes it so important.
Yeah, back to basics. Potassium 101.
So think of potassium as this essential element. It's like the conductor of an orchestra, and the orchestra in this case is our body. It's vital for our nerves to communicate, for our muscles to contract, even for our heart to beat properly.
Oh yeah, can't forget the heart.
Right, it plays a huge role in cardiac conduction, that electrical signaling that keeps everything in rhythm.
Right.
And then there's the whole balance of acids and bases.
Keeping our pH in check.
Exactly. So when potassium levels go out of whack, things start to fall apart. And that's when we start seeing those clinical features.
Okay, so let's talk about those. And when it comes to potassium and the heart, the ECG is our best friend.
Oh, for sure. It's like our early warning system. One of the first things we might notice is those T waves start to flatten out.
Flattened T waves, classic sign.
Yeah, and it's all about how the heart repolarizes. Potassium is key for that. So when it's low, that repolarization, that electrical reset takes longer, hence flat T waves.
And as it gets worse, what then?
Then those U waves start to become prominent, those little humps right after the T wave. They're kind of subtle but important. They probably represent delayed repolarization in those special fibers within the heart muscle.
Purkinje fibers, right.
Exactly. So you've got the flattened T waves, those prominent U waves.
Anything else?
Oh yeah, you might also see ST segment depression and a prolonged QT interval. Now, measuring that QT interval can get a bit tricky. Sometimes that U wave kind of blends with the T wave, making the QT look longer than it is. But either way, that delay in repolarization is what sets the stage for those nasty arrhythmias. Torsades de Pointe, especially.
Not a rhythm we want to see.
Definitely not. And when hypokalemia gets really severe, you start worrying about even more serious ventricular arrhythmias, premature ventricular contractions, ventricular tachycardia, even ventricular fibrillation.
So those are the big red flags on the ECG. Are there any other findings we should be aware of, even if they're not quite as specific to hypokalemia?
Yeah, there are a few others. Sometimes you see a bigger P wave, a longer PR interval, maybe even sinus bradycardia, and in some cases, even atrial fibrillation. But it's important to remember these things can have other causes too, so you got to look at the whole clinical picture.
The context is everything.
Exactly. Now, apart from all that electrical stuff on the ECG, there are other symptoms that might tip you off.
Right, beyond the heart.
So patients might complain of fatigue, like they just can't get going, or muscle weakness.
She's feeling blah, basically.
Yeah, like their body's made of lead. And depending on how low that potassium is, it can range from mild to pretty debilitating. I mean, in severe cases, you can even see ascending paralysis.
Wow, that's serious.
Yeah. And of course, there's always the risk of those arrhythmias we talked about.
Okay, so we've got a good idea of what to look for now, but the million-dollar question is, why is this happening in the first place? What's causing this drop in potassium?
That's where the detective work begins. And a good way to start is to ask yourself, where's the potassium going? Is it being lost through the kidneys, or is it something else entirely?
Renal versus non-renal, right?
Exactly. That's the first big fork in the road.
Okay, so let's take the non-renal route first.
Yeah.
What kind of scenarios are we talking about here?
All right, so if we check the urine potassium and it's low, say less than 20 MEQL, or that spot potassium to creatinine ratio is less than 1.5.
That's our clue.
That's our clue. It means the kidneys are doing their job, trying to hold on to that potassium. So the problem is likely somewhere else. And a lot of the time, it's the GI tract.
Makes sense. You lose a lot of fluids and electrolytes through vomiting and diarrhea.
Oh, for sure. Vomiting is a big one. You're losing potassium directly. Plus, it can trigger metabolic alkalosis, which messes with potassium balance even more.
Right. The body tries to compensate.
Then you've got diarrhea, more potassium lost in the stool. Laxative abuse can do the same thing. Ileostomies, too. And there's this less common thing, villus adenoma. It's a tumor in the rectum. It secretes a ton of mucus, and guess what? Potassium gets lost with that, too.
Oh, wow. Interesting. So lots of ways to lose potassium through the gut.
Yeah, it can really add up. But it's not always about losing it. Sometimes it's about where it's hiding.
Hiding?
Well, kinda. We call it transcellular shifts. That means potassium moves from outside the cells into the cells, so your blood levels drop.
Sneaky. So what causes that?
Oh, lots of things. Insulin, for one.
Makes sense. It helps sugar go into cells, maybe potassium too.
Exactly. It stimulates that sodium-potassium pump, pulling potassium in. And this is super important in DKA. You give insulin, blood sugar drops, but potassium can plummet too if you're not careful.
That's why we always got to be checking potassium in DKA.
Always. And it's not just insulin. Beta agonists, like your albuterol for asthma, they can shift potassium too. And remember how we talked about alkalosis with vomiting? Well, alkalosis from any cause can do the same thing. Hydrogen out, potassium in.
To keep things balanced.
Right. Electrically neutral. Then you've got these rarer things like thyrotoxic periodic paralysis, sudden potassium shifts, muscle weakness. It's fascinating, but we won't go down that rabbit hole today.
Maybe another deep dive. Okay, so we've covered the non-renal causes. Let's switch gears to the kidneys. What's happening when the kidneys are the culprits behind hypokalemia?
So if that urine potassium is high, above 20 MEQL, or that potassium to creatinine ratio is above 2.5, that's our red flag. The kidneys are letting go of potassium when they shouldn't be.
They're wasting it.
Exactly. And the usual suspects here, diuretics.
Of course. Lupin thiazides.
Yeah, those are the big ones. Loop diuretics, like furosemide, they block this cotransporter in the loop of Henle. It's called the sodium-potassium chloride cotransporter, if you want to get technical.
Catchy name.
Right. Anyway, so blocking that increases sodium chloride and potassium excretion. Plus, it sends more sodium downstream, which triggers aldosterone release. And aldosterone loves to get rid of potassium.
A cascade of potassium loss. And thiazides.
Thiazides, like hydrochlorothiazide, they work a bit further down in the distal convoluted tubule. But they basically do the same thing. Block sodium reabsorption, trigger aldosterone, potassium goes bye-bye.
So diuretics are public enemy number one. What else can cause this renal potassium wasting?
Well, endocrine disorders are a biggie. Hyperaldosteronism, for example. Too much aldosterone, whether it's primary from the adrenal gland itself or secondary from something else driving renin up.
And aldosterone loves to get rid of potassium, as you said.
It's obsessed with it. So you get increased sodium reabsorption and potassium excretion.
Classic trade-off.
Then there's Cushing's syndrome. Too much cortisol. And at high enough levels, cortisol acts like aldosterone, leading to potassium loss.
Sneaky cortisol.
And even hyperthyroidism can get in on the action. It revs up that sodium-potassium pump in the kidneys, potentially pushing potassium out.
Wow. So many different players. And then there are all those RTAs, right? The renal tubular
Oh, yeah,
acidosis.
those can be tricky. There are a couple of main types. Type 1, the distal RTA, the problem is in the distal tubule. It can't secrete hydrogen ions properly.
You get acidosis.
You got it. Metabolic acidosis. And because of all that, sodium reabsorption gets messed up too. More sodium going downstream, more potassium getting kicked out. And here's the thing with type 1 RTA, the urine pH stays high, above 5.5, even though the body is acidic.
That seems counterintuitive.
It is, but it's a key feature. Now, type 2 RTA, the proximal one, the issue is with bicarbonate reabsorption. It's impaired. So initially, you get more bicarbonate and sodium and potassium getting dumped in the urine.
But then what happens?
Well, once the bicarbonate in the blood drops low enough, the distal tubule can actually acidify the urine. So the urine pH can actually be low, below 5.5, even though the body is still acidotic overall.
Ah, so urine pH can flip-flop in type 2?
Exactly. It can be a bit confusing, I know.
And then we have those genetic syndromes that can mess with potassium balance.
Oh, yeah, a whole bunch of them. Like Barter's syndrome, it's a group of genetic defects in the thick ascending limb of the loop of Henle. Sounds familiar, right?
Kind of like loop diuretics.
Exactly. It mimics their effects.
Yeah.
So you get hypokalemia, metabolic alkalosis, but usually normal or even low blood pressure. Renin and aldosterone are high, though, because the body is trying to compensate.
It's trying to hold on to sodium.
Right. Then there's Gittleman syndrome, which is like a genetic thiazide diuretic. Hypokalemia, metabolic alkalosis, but often with low magnesium, too, and low calcium in the urine. Blood pressure can be a bit low or normal, and again, renin and aldosterone are usually high.
So mimicking those diuretics again.
Exactly. Now, Little syndrome is a different beast altogether. It's a gain-of-function mutation in the sodium channel in the collecting duct.
So sodium goes crazy.
It goes nuts. Increased reabsorption, high blood pressure, hypokalemia, metabolic alkalosis. But here's the kicker. Renin and aldosterone are low.
Because the body's trying to turn things down.
Exactly. And finally, there's apparent mineral corticoid excess, or AME. It's a mouthful, I know.
Let's just call it AME.
AME it is. So this one involves an enzyme deficiency. Cortisol normally gets converted to cortisone, which doesn't have much effect on mineral corticoid receptors. But in AME, that conversion doesn't happen properly. Cortisol keeps acting like aldosterone, and you get the same picture: high blood pressure, hypokalemia, suppressed renin, and aldosterone.
Interesting. So lots of different ways those genes can mess with potassium.
Oh, yeah, it's like a whole other world down there in the tubules.
Now, aside from diuretics and those genetic syndromes, are there any other medications that can contribute to hypokalemia?
Absolutely. Some medications can directly damage the tubules, leading to potassium loss. Amphotericin B, an antifungal, and cisplatin, a chemo drug, are two examples.
So those are ones to watch out for.
Definitely. And remember how we talked about magnesium earlier? Well, low magnesium itself can actually worsen hypokalemia.
How so?
Magnesium is important for the function of potassium channels in the kidney. So if magnesium is low, those channels don't work properly, and more potassium gets lost in the urine. Makes it really hard to fix the hypokalemia until you fix the magnesium.
That makes sense. It's all connected. Okay, so we've explored all these different causes, this whole spectrum of possibilities, but how do we actually figure out what's going on in a patient? What investigations do we do?
Well, first things first, we got to make sure the hypokalemia is real.
Rule out lab errors.
Exactly. Repeat the test, make sure it wasn't just a fluke. And we also got to think about pseudohypokalemia.
That's when it looks like hypokalemia on paper, but it's not really.
Right. It can happen if there are a ton of white blood cells or platelets in the sample. They gobble up potassium, making it look artificially low.
So confirm the basics first. Then what?
Then we got to look at the acid-base status. Blood gas, either arterial or venous, will give us the pH, the bicarbonate, the PCO2. It helps us figure out what's driving the potassium problem.
So metabolic acidosis could point towards GI losses or RTA, while metabolic alkalosis could suggest vomiting, diuretics, or too much mineralocorticoid activity.
You got it. It's like getting a compass reading.
Okay, compass pointed in the right direction. What's next?
Urine potassium. That's our next big clue.
To see if the kidneys are holding on to potassium or dumping it.
Exactly. Less than 20 LUQL usually means it's not the kidney's fault. It could be extra renal losses or transcellular shifts. But if it's high, above 20, then we got to focus on the kidneys. We can also use that spot urine potassium to creatinine ratio. Less than 1.5 is probably not renal. Above 2.5, more likely renal.
Okay, so high urine potassium, kidneys are the culprit. Is that when the TTKD comes in?
You bet. The transtubular potassium gradient.
I've heard of it, but remind me, what is it exactly?
It's a calculated value that tells us about potassium concentration at the very end of the nephron, the collecting duct, where all the fine-tuning happens.
And the formula, don't make me remember.
Don't worry, I won't quiz you. It's urine potassium over serum potassium divided by urine osmolality over serum osmolality.
Right, that rings a bell. But what does it actually tell us?
It tells us how well those collecting ducts are listening to aldosterone. When aldosterone is high, you expect a high TTKG, meaning potassium is being secreted. But if the TTKG is low, less than 4, that means the kidneys aren't secreting enough potassium even though levels are low. Could be low aldosterone or some kidney problem.
And a high TTKG.
High, above 7, means the kidneys are secreting too much potassium. Could be high aldosterone or just a lot of fluid going through the distal nephron, like with diuretics.
Okay, TTKG, got it.
Yeah.
So what's the last piece of the puzzle, especially when we're thinking about hormonal causes?
If we're suspecting an endocrine issue, we got to check those renin and aldosterone levels.
The dynamic duo.
Right. And the renin-aldosterone ratio, the ARR, that's a great screening tool for primary hyperaldosteronism. Low renin, high aldosterone, that's pretty classic.
And if they're both low?
Both low, especially in someone with high blood pressure, could make you think about things like Little syndrome or AME.
So we put it all together, the clinical picture, acid base, urine potassium, TTKG, renin, aldosterone. That's how we get our diagnosis.
Yeah, it's like detective work, connecting all the clues.
Now, are there any other tests we might do or things we should think about during the diagnostic process?
Sometimes, if things aren't adding up, and especially if there's a strong family history of electrolyte problems, we might consider genetic testing.
With those genetic syndromes we talked about.
Exactly. And a thorough history is key, always.
Medications, diet, all that good stuff.
Yeah, medications are huge, including over-the-counter stuff and supplements. You got to know everything they're taking. And diet, don't forget about licorice. That can mess with things too.
Licorice? Really?
Yeah, it contains a compound that inhibits that enzyme we talked about in AME. So you can actually get licorice-induced hypokalemia.
Wow, who knew? The things you learn. And of course, a good physical exam is always important.
Absolutely, especially blood pressure.
Okay, so we've diagnosed our patient with hypokalemia. We know the cause. What's next? How do we fix it?
Well, the big picture is this. Fix the underlying cause, replace the potassium, and watch them like a hawk.
Monitor it closely.
Constantly. You want to correct the hypokalemia, but you don't want to overshoot and end up with hyperkalemia.
Right, that's just as bad. So when it comes to replacing potassium, do we go oral or IV?
It depends. If it's mild to moderate hypokalemia between 3.0 and 3.5 or 2.5 and 3.0, and the patient is stable, oral potassium is usually fine.
Potassium chloride, right?
KCl,
Right.
yep. Usually 40 to 100 milliliter per day, split into multiple doses.
To avoid upsetting their stomach.
Exactly. And there are extended release formulations that are a bit easier on the gut.
Good to know.
But no matter what, you got to keep checking those potassium levels and adjust the dose as needed.
Titrate, titrate, titrate.
And of course, you can encourage them to eat potassium-rich foods, but be careful with those salt substitutes that contain potassium.
They can sneak up on you.
Now, if the hypokalemia is severe, below 2.5, or if the patient is symptomatic, regardless of the number, then IV potassium is the way to go.
And that's when we need to be extra careful.
Absolutely. Continuous cardiac monitoring is a must. For peripheral IV, we usually keep the concentration at 40 milliQL max and the rate no faster than 10 to 20 milliQ per hour.
To avoid irritating the vein.
Exactly. If they have a central line, you can go a bit higher, up to 100 milliQL and 40 milliQ per hour.
But that's ICU level stuff.
Exactly. Close monitoring is key, checking potassium every couple of hours, watching that ECG like a hawk. And once they're stable, above 3.0, you can usually switch back to oral.
So that's the general approach. But you mentioned some special situations like DKA.
Oh yeah, DKA is a whole other ballgame. Got to be really proactive with potassium there. Remember, even if the potassium seems okay at first, those patients are usually depleted.
Because of that shift with acidosis and insulin deficiency.
Right, and when you start giving insulin, potassium rushes back into cells, and you can get a sudden, dangerous drop. So before you even think about insulin, check that potassium.
And if it's low.
If it's below 3.3, hold the insulin and start IV potassium, usually 10 to 20 milliQ per hour. Get that potassium up first.
Safety first.
Absolutely. And of course, continuous cardiac monitoring is essential. If the potassium is between 3.3 and 5.0, you can start the insulin, but add potassium to the IV fluids, 20 to 40 milliQ per liter, and check levels every couple of hours. If it's above 5.0, you can probably hold off on the potassium, but watch it closely and start replacing if it dips down with the insulin.
Lots of numbers to keep track of.
Oh yeah, DKA is a juggling act. And don't forget about magnesium and phosphorus. They can get low too, and that can mess with potassium.
So many things to consider. Are there any other special scenarios we need to be aware of?
Well, always remember about magnesium. If it's low, fix that first. Otherwise, your potassium repletion might not work.
Right, they go hand in hand.
In cardiac surgery, we like to keep potassium a bit higher, above 4.0, because you really want that heart to be happy.
No arrhythmias, please.
Exactly. And with digoxin toxicity, even a little hypokalemia can be dangerous.
Because it makes the heart more sensitive to digoxin.
Exactly. So you got to be careful correcting it. Aim for the higher end of normal in that case.
Good to know.
And finally, if a medication is causing the hypokalemia, see if you can adjust the dose or switch to something else.
If possible, of course.
Right. And you might need to add potassium supplements or a potassium-sparing diuretic to counteract the loss.
Okay, that makes sense. Now, we've talked a lot about potassium, but we know it doesn't exist in isolation. How does it interact with other electrolytes?
Great point. You can't just think about one electrolyte at a time. They're all connected. We've already talked about magnesium, how low magnesium can worsen hypokalemia. And it's not just about the kidneys. Magnesium is also a cofactor for that sodium-potassium pump.
Essential for everything to run smoothly.
Exactly. Now, with calcium, the link is a bit less direct, but they can definitely be involved together.
Like in those renal tubular disorders.
Right. RTAs, Bartter syndrome, Gittleman syndrome, they can all have abnormalities in both potassium and calcium.
Interesting.
And Gittleman syndrome often has hypokalemia, hypomagnesemia, and hypocalciuria, low calcium in the urine.
It's like the trifecta.
Kind of. And then there's the whole world of acid-base disorders, which can get really complex.
Oh yeah, always a fun time.
So metabolic alkalosis, for example, it can both cause hypokalemia and be made worse by it.
A vicious cycle.
Exactly. The alkalosis shifts potassium into cells, and it also increases renal potassium loss.
To maintain that electrical neutrality.
Right. And then hypokalemia itself can actually perpetuate the alkalosis by stimulating bicarbonate reabsorption and hydrogen ion secretion.
So it's like a double whammy.
Exactly. And when you see metabolic alkalosis with hypokalemia, checking the urine chloride can help you figure out what's going on.
How so?
If the urine chloride is low, less than 20 MEQL, it suggests a chloride-responsive alkalosis, like from vomiting or diuretics. But if it's high, above 20, it could be a chloride-resistant alkalosis, often from mineralocorticoid excess or really severe potassium depletion.
Another clue to guide us. What about metabolic acidosis? How does that play with hypokalemia?
That one's a bit more tricky. It can go either way, depending on the cause. In some cases, like with certain RTAs or severe diarrhea, you can get hypokalemia because the kidneys are wasting it or it's being lost directly from the gut.
Makes sense.
But in other situations, like DKA, you might see hyperkalemia initially because the acidosis pushes potassium out of the cells. But then when you treat the DKA with insulin, hypokalemia becomes a big concern.
Because insulin pulls potassium back into the cells.
Exactly. And measuring the urine anion gap can help differentiate things. Negative anion gap usually means GI losses. Positive anion gap points more towards a renal cause.
Another tool in our toolbox. And what about those respiratory acid-based disorders?
Well, with respiratory alkalosis, you often see hypokalemia because the low PCO2 shifts potassium into cells.
Classic hyperventilation.
Right. But with respiratory acidosis, hypokalemia isn't typical. If you see it, you got to think about other factors like diuretics or other electrolyte problems.
Okay, wow, that was a whirlwind tour of hypokalemia.
It's a lot to take in, I know.
But super helpful. So for our listeners out there, especially those prepping for exams, what are the absolute must-know takeaways?
I'd say first, really understand the definition of hypokalemia and how we classify it based on severity. Then, know those causes inside and out. Renal, non-renal, genetic, hormonal, drug-induced, the whole shebang.
A long list.
It is. But you got to be able to recognize those patterns. And then mastering the investigations is key. Urine potassium, TTKG, renin, aldosterone, those are your diagnostic weapons.
Oh yeah, got to know when to use them and how to interpret them.
Exactly. And then treatment. It's not just about giving potassium, it's about understanding the underlying cause and tailoring your approach.
Like in DKA, where you have to be so careful.
Right, and don't forget about those other electrolytes and the acid-base status. They're all interconnected.
It's like a complex web.
It is. But once you start to see the connections, it all starts to make sense.
This has been a great deep dive. I feel like I'm brushed up on my potassium knowledge big time.
Glad to hear it.
And for everyone listening, I hope you feel the same way. This is just the beginning, though. Take this knowledge, review those case studies, practice interpreting ECGs, really think about how different clinical scenarios might change your approach. And don't be afraid to dig deeper, to explore those more complex cases. That's how you really solidify your understanding.
Couldn't have said it better myself.
All right, thanks for joining us for this deep dive into hypokalemia. Until next time, keep learning and keep diving.